So we are now on surgery word on chronicles 2. This is the last part. Okay, so in surgery chronicles we usually talk about the things which are covered on the word, so which include just going through questions and some parts we even give out answers. So there are things on topics which maybe you have not come across on, so we can cover them here. Okay, so like on burns, so a patient with burns, so a question comes, what are the effects of biofilm in burns? So what do you think is the effect of biofilms in burns? Then the other thing is why we don't give blood in the first 24 hours of burn event. I think this is the most common question which is asked on the words. So why don't we give blood in the first 24 hours of burn event? Okay. Then 3 ways to give blood to a Jehovah's Witness believer. So what are the 3 ways? Knowing say a burn patient present with anemia, and they of course they are Jehovah's Witness. They choose to get blood. So what are some of the ways you can give them blood? Okay. Partial IO. Explain why there could be defecation in partial IO. So what do you think patients who present with partial IO have can actually defecate? Then skin graft, what's the definition? Those are the indications. So and also complications and the types. You need to know what skin grafting is and the classification as well. Then storage of harvests and at what temperature is the skin kept. And the other thing is what's the name of the machine for expanding thick skin when doing skin grafting. Then osteomyelitis features, and so it's more like symptoms of osteomyelitis, and of course osteomyelitis features on X-ray. Then we go to a breast pathology. So mammogram, age group and rationale. So everyone knows that ultrasound is less than 35, then mammogram more than 35. So why is the 35 more than 35 age group? What's the rationale? Okay, differences between staging and grading of breast pathology. Then differences between benign and malignant, and what are some of the hallmarks of breast tumors. Then ABCs of tumor, then tumor markers for breast CA, then which chromosome are related to BRCA, then blood supply to the breasts. I think this is easy. Then levels of lymph nodes. So I think this is, let's go through the levels. Okay, the levels of lymph nodes. So we have level 1, level 2, level 3. So we have 3 levels. So under level 1 we have nodes such as the anterior, that's the ones which are found in level 1. So we have anterior, lateral, posterior. Then under level 2 we have central. Then under level 3 we have apical. Then in total we have anterior, posterior, lateral, apical, central. Then mammogram. Okay, those are just some notes, but let's skip to BRCA. So I know you are wondering what BRCA is. So mutation of tumor suppressor genes BRCA1 and BRCA2 is thought to be involved in high risk of breast carcinoma. Then we have BRCA1 mutation is having more risk than BRCA2 mutation. Then BRCA1 is found on the long arm of chromosome 17, and it is seen in breast medullary carcinoma and ovarian carcinoma. Then BRCA2, let's go to BRCA2, is found on the long arm of the chromosome 13, and it's associated with breast cancer in males. So that's BRCA2. Okay. Then snake bite, BPH, or prostate CA. So then what are the principles of principles of management of snake bite. Then there are, I think the other question which usually comes or is asked on the words is the 7 principles management of snake bites. 7 principles. Then the other question is what type of shock is caused by a poisonous snake and how. Then 5 conditions in which GRE is important. So BPH, prostate, prostatitis, IO, hemorrhoids, rectal CA, anal CA. Then of course all males who present in surgery. And there is even a famous quote where they say there are only 2 indications where let me just say 2 contraindications for non doing DRE. Either you don't have a finger or the patient doesn't have an anus. So those are the 2 contraindications why you shouldn't do a DRE. Okay. Then what are the 5 factors that would influence the rise of PSA? So we have surgical causes such as BPH, prostatitis, prostate CA. Then other factors we can have riding a bicycle, elderly patient, prostate size. Then medications to lower PSA. What's some of the medications that can lower PSA? Then 5 major concerns with regards to prostate CA. Then we're now on a patient with appendicitis. So atypical positions of appendix. So everyone knows the typical positions such as the retrocecal, pre-radial, posterior, pelvic. So what are they now? What are the atypical positions now? Where else can you find the appendix apart from those typical ones? Then CT scan features of appendix. So what are the CT scan features of appendix? Then method of scoring for children. So the answer is PASS score. It's called the pediatric appendicitis score. Then staging of acute appendicitis. So we have 1, that's staging. Stage 1 is normal appendix. Stage 2, uncomplicated acute appendicitis. Stage 3, complicated acute appendicitis. Then grading. Now we have grading of acute appendicitis. We have grade 0 to 5. Grade 0 is a normal looking. Grade 1, that's if there's redness and edema. Then grade 2 if it's fibrin. Then in grade 3 we have grade 3A when there is segmental necrosis. Grade 3B when there is base necrosis. Then grade 4 we have grade 4A when there is an abscess. Grade 4B when there is regional peritonitis. Then grade 5 when there is diffuse peritonitis. Then we have appendicitis. Appendicitis continued. What is complicated appendicitis? So how do you define complicated appendicitis? So this is when there is perforated appendicitis which leads to acute obstruction, and there is periappendicular abscess which leads to peritonitis and eventually portal pyemia. Then the other way we can define complicated appendicitis is perforated appendicitis, periappendicular abscess or peritonitis, defined as acute inflammation of the peritoneum secondary to infection of the appendix. I think the last part is the easiest way of defining. So acute inflammation of the peritoneum secondary to infection of the appendix, that's complicated appendicitis. Then there is what they call Valentino syndrome in appendicitis. So we have this is when gastric perforation. So someone with a gastric perforation and the blood goes in the right iliac fossa and it gets the appendix inflamed. When the appendix inflamed, it becomes inflamed secondary to gastric perforation. That's called the Valentino syndrome, also known as Valentino appendix. So the other way we can define it is a clinical syndrome of right lower quadrant or right iliac fossa pain secondary to a perforated peptic ulcer, which is an important differential for acute appendicitis. Then this is the PASS score, the pediatric appendicitis score. So we have the mnemonic. For elderly patients, we have for adults we have Mantrails. Then for pediatrics we have Mantcells. MANTCELLS. EL, month cells. So M, sorry about that. Okay, we are now back. M for migration of pain, A for anorexia, N for nausea or vomiting, T for tenderness in the right lower quadrant, C for coughing, hopping or percussion pain, then E for elevated temperature, which is the same fever we're talking about, then the L for leukocytosis, then the S for shift of WBC, then that's month cells. So that's the pediatric appendicitis score. Okay, so this is the same thing, explaining the same thing. So you can pause and again go through the pediatric appendicitis score. Then hemorrhoids. So color of thrombosed hemorrhoids. Why is it dark? So why are thrombosed hemorrhoids dark? Okay, why are internal hemorrhoids painless while external hemorrhoids painful? So the way you can remember is external ectoderm. So let's go. So internal hemorrhoids arise from the endoderm, and the endoderm is as autonomic innervation, hence they are painless. While the external hemorrhoids arise from the ectoderm, and the ectoderm has somatic innervation, hence it is painful. So that's the way it is. Okay, then potopaemia in hemorrhoids. So how does it occur? Then how to differentiate pyemia from pyogenic abscess? So this is easy, but because pyogenic abscess is localized, then if the same pyogenic abscess moves and embolizes in the liver, it becomes potopaemia. Okay, then osteomyelitis. The gold standard in diagnosing osteomyelitis, of course, is pathology. You get a biopsy, then you do your MCS. Then differences between acute and chronic osteomyelitis. So you can differentiate acute and chronic osteomyelitis in terms of two, okay, in duration and sequestrum. So duration, acute is less than 2 weeks, chronic is more than 6 weeks. Then sequestrum, in acute it is absent, whilst in chronic it is present. Then why is it hard to treat osteomyelitis? So why is it difficult to treat osteomyelitis? Then WBC on hemogram in osteomyelitis. How is the white cell count in osteomyelitis? Normal on hemogram, then the ESR and CRP are elevated. Then Codman's triangle, when you do X-ray, what is it? So what does it show? So it shows a periosteum that is being lifted, and it is a radiodiagnostic sign in osteosarcoma, Ewing sarcoma, and osteomyelitis itself. That's Codman's triangle. Then X-ray in first week of osteomyelitis, it is not helpful. MRI is the recommended diagnosis in osteomyelitis in the first week. Then mention 3 abscesses that are associated with osteomyelitis. We have Brody's abscess, intraosseous abscess, and cord abscess. And the famous question is why is it called cord abscess? Then 5 investigations to carry out when you have a bone abscess. So of course MCS, cytology, pathology, PCR. So those are some of the investigations when you have a bone abscess. Then why is multidisciplinary approach important in osteomyelitis? So why? Then staging of osteomyelitis, you need to know how to stage. And this is the Codman's triangle we were talking about, which is showing the periosteum that is being lifted. Then of course this is the periosteal reaction from solid, lamellated, ascend bursts, and Codman's. Then this is the classification of osteomyelitis using the Sieni and Mara classification. So we have anatomical type and physiological class. So anatomical type, we have mnemonic MSLD, type 1 medullary, type 2 superficial, type 3 localized, type 4 diffuse. Then physiological class, we have A for normal host, B for local systemic compromised host, then C treatment western disease. Then thyroid disease, so we need to know the embryology of thyroid, thyroglossus ductus. So a patient with thyroglossus duct cyst, when you tell them to protrude their tongue, you find that the thyroglossus duct cyst will move with tongue protrusion due to its attachment to the hyoid bone, where the tongue is also attached to. Okay. Then antibodies to test for in thyroid diseases. You need to know what are the antibodies you need to test for in thyroid disease. Mention autonomic diseases of thyroid. So we have Hashimoto's disease, Graves' disease, and you need to know in which one is for hypo, which one is for hyper. Okay. Then position of examiner when doing thyroid examination. You can do it in front, back, and of course you need to know what you'll be looking for. Then between hyper or hypothyroidism, which one causes periorbital edema? And the answer is hypothyroidism. Then complication of thyroidectomy, indications and precautions. So bearing in mind that for you to do thyroidectomy, the patient need to be euthyroid, which means they shouldn't be hyper or hypo, but and they shouldn't be uncontrolled hyper or hypo, should be controlled and should be euthyroid. So what are the indications, complications you need to know? And what is the other last part is what is shock, then what is permissive hypotension, and what is damage control in shock. We go to hernias now. So incarcerated versus strangulated, I think we mentioned. So if the contents of the hernia are not able to be reduced, the hernia is considered incarcerated. Then a strangulated hernia occurs when the hernia contents are ischemic due to a compromised blood supply. And of course, like we said previously in the other in stage-wide round chronicles 1, we said incarcerated hernia, clinical diagnosis, strangulated hernia, intraoperative diagnosis. Then direct versus indirect inguinal hernia, what's the differences? Triangle involved in indirect hernia and its boundaries. So we are talking about the Isobex triangle. The borders, we have the IEA, IL, and the LBO, RA. So those are just short forms for the borders of the Isobex triangle. Then contents of the inguinal canal, you need to know the contents of the inguinal canal. Management of hernia and complications of surgical intervention. What is the Richter's hernia? So Richter's hernia, this is when there is a part or a portion or circumference of the abdominal, not of the abdominal, sorry, but of the part of the bowel. So when there is a part of circumference of a bowel, that's Richter's hernia. Then anatomy versus eniography versus enioplasty, you need to know the differences. Amiens hernia versus Richter's Litters. Amiens hernia versus Litters hernia. So Litters hernia is one which contains Michael's diverticulum. Then Amiens hernia is one which contains the appendix trapped within an inguinal hernia. Then examination of hernia and what is Siemens test and how do you do it. So these are the schematic these are the schematic contents. So we have the rule of threes. So we have three fascias, then three fascia, mnemonic ICE, ICE, ICE. So I for internal spermatic fascia, C for cremasteric fascia, E for external spermatic fascia. Then we have three arteries. So three arteries we have ACT, ACT. A for artery of the vas deferens, C for cremasteric artery, T for testicular artery. Then three veins. So the veins correspond to the arteries. So we have testicular vein, that's what it means. Then together all the veins form the papilliform plexus. Then we have three important structures, which is the vas deferences in males, round ligament in females. Then we have the hernia sac if there is hernia. Those are the three structures. Then the three nerves, we have mnemonic SIG, SIG. So S for sympathetic nerve, I for ilioinguinal nerve, then G for genital branch of the genitofemoral nerve. Those are the schematic code contents, rule of threes. Then this is the difference between inguinal, direct inguinal and indirect. So we can go to the next, we can pause and go through. I want to talk about Zeeman's test, named after Stephen A. Zeeman, surgeon at Providence Hospital. And okay, so the aim of this test is to differentiate and diagnose the indirect inguinal hernia, direct inguinal, and femoral hernias. So that's the aim. Then method, how do you do it? So you ask the patient to lie in supine position and reduce the hernia. So you have to reduce it, and then you have to keep the index finger over the deep inguinal ring, your middle finger over the superficial inguinal ring, and the ring finger over the saphenous opening. So as you've seen in the image, DIR, SIR, and saphenous opening. Okay. Then you ask the patient to cough and feel the expansor impulse on coughing and diagnose the hernia according to the site of impulse. Then how do you interpret the Zeeman's test? So Zeeman's technique. So when the impulse is felt on the index finger, then on where there is the deep inguinal ring, that's an indirect inguinal hernia. When the impulse is felt on the middle finger, it's a direct inguinal ring. Then inguinal hernia, direct inguinal hernia. Then if the impulse is felt on the ring finger, then the hernia is a femoral hernia. Okay, that's the Zeeman's test. Fourniers gangrene now. So types of debridement in Fourniers gangrene, you need to know the types. Merenez hernia, so you need to know what Merenez hernia is. Merenez gangrene. I'm behind on hernias. Okay, so Merenez gangrene. Then complications of Fourniers gangrene, causes of mortality in Fourniers gangrene. So of course, bearing in mind you have septic shock and late presentation, what other things can cause. Then types of surgical debridement, depending on severity. So we can have primary debridement, which is done in the first 24 hours. Then we can have secondary debridement, which is done after 48 hours, which is the second loop. Then we have tertiary debridement, which can be done in the third loop. So these are there are a lot of classifications, so this is depending on severity. Then microbial classification of necrotizing fasciitis. So how do you classify microbial classification of neck fascia? So we have type 1 to 4, that's the classification. So type 1 polymicrobial, type 2 monomicrobial, type 3 anaerobic, type 4 fungal, that's the classification. Then question 7, importance of triple therapy in Fourniers gangrene. Of course, you know that it's empirical therapy, hence it's to get a specific or type of neck fascia and divert the antibiotics, meaning that when you see a patient with Fourniers gangrene, you've done your MCS, you need to know which one is causing what. So first you need to do empirical therapy. So after you've gotten your investigations, and then start your empirical therapy. Then after you get the results, then you divert the antibiotics and treat the exact thing causing the neck fascia. Then head injury. So what is the difference between my MRC and CT scan in head injury? What is Bartol's sign? What are Kuhn-Ayres? So we talked about this. And if you didn't watch surgery, what the chronicles 1, you need to watch because we defined this. The differences between concussion and contusion. So the definitions are differences. Then the locations. So the brain, if the injury involved the brain, then it was a contusion. While if it's the skull, it's a concussion. So if the patient don't have an injury to the brain, then there was momentary loss of consciousness, they know that okay, it should be a concussion. Then why don't we give dextrose in head injury? So you know that of course edema, we are afraid of causing edema, we need to increase the ICP. But how? So you know that dextrose contains glucose plus water, and then the glucose is absorbed and only water remains. So then water, you know that it's increases hydrostatic pressure at that point, which will lead to leak of fluids, and again causing edema and increased intracerebral pressure. Then how to prevent secondary brain injury. So you know that there's primary and secondary. So how do you prevent the secondary one? Then why do we elevate the head in head injury? Then this is the pros and cons of CT scan and MRI. So you need to go through. You can pause and you peruse through this. Okay. Then dysphagia. Let's talk about dysphagia now. So why do we ask for prior surgery in patients with dysphagia? Can psychiatric conditions and drugs cause dysphagia? And if yes, which ones? A CT scan is necessary in which dysphagia condition? So at least 3 investigations to diagnose the exact cause of dysphagia. So of course we have barium swallow, manometry, and endoscopy. Then what are the benefits of using endoscopy in dysphagia? So we know that it identify exact cause and it is therapeutic. So that's the benefit. Then principles of management of dysphagia. Complications of dysphagia, we have dehydration, malnutrition, aspiration pneumonia or aspiration pneumonitis can occur. Differences between motility and mechanical dysphagia conditions. So motility, we have solid plus liquid, and peristalsis issues, while mechanical is just solid to solids. Then most likely due to a physical blockage. The neurotube defects, then the question is, why is folic acid important in antenatal? The famous question which is being asked in neurotube defects. Then differences between meningocele and meningomyelocele. Then how many nerves are serviced by the spinal cord? So how many nerves are serviced by the spinal cord? Importance of plastic shunt or shuttle in management of myelomeningocele. Then types of hydrocephalus shunts that you know, and the classification of hydrocephalus. Of course, this is the most common thing which is seen. Benefits of 24 hours early surgery in spinal bifida. And some of the things is that you reduce damage to the nerves, veins, and hence prevent further problems. That's one of them. So what are the other benefits? Then what's spinal tethering? So a tethered spinal cord syndrome is a neurological disorder caused by tissue attachments that limit the movement of the spinal cord within the spinal column. Then attachments may occur congenitally at the base of the spinal cord or the conus medullaris, or they may develop near the site of an injury to the spine. That's spinal tethering or tethered spinal cord syndrome. Then this is meningocele, and that's myelomeningocele. And the thing is, as you can see here, there is the spinal cord, so to say, in meningocele is absent. This is meningocele. In meningocele it's absent. Then in meningomyelocele or myelomeningocele it is present here. So in meningomyelocele, the spinal cord is negative transillumination and it is more severe. That's meningomyelocele. Then in meningocele, okay, in meningocele you have just CSF, positive transillumination, less severe as compared to meningomyelocele. So these are the differences between meningomyelocele and meningocele. So there's in meningocele there's just CSF, positive transillumination test, less severe. Okay, this is the end of the first. This is the second surgery word round chronicles. And if you haven't watched the previous one, please watch, subscribe, like this video, and share to people who are in surgery department so that they too get to feel of these questions. Okay.